Alright, so my name is Chad Morn. The date is December 12th, 2022, and I'm about to begin my Unit 4 case connections. I chose to do my two questions on gout and megaloblastic anemia. And here we go. We're going to get right into it here. Alright, so the first case is about gout. It's a 47-year-old man with severe pain in his great toe, and his plasma uric acid levels are elevated to 10.5 and 215. And so the question is, what is the best explanation for the presentation of gout in this individual? So developing gout can be directly related to ingesting high amounts of fructose via many different food sources like soda, beer, um, fruits, any type of sugary candy or anything. Fructose is converted into a purine, which is further converted into uric acid, and these high amounts of uric acid can deposit themselves um, into uric acid crystals into joints in the body. The most common places for these deposits are in joints like your fingers, your toes, and your knees and such. I have some pictures later to show you. So a diet high in fructose leads to increased amounts of purines, which leads to increased amounts of uric acid crystals, which causes the person to get gout. And so the root of the patient's gout is due to overproduction of purines. This, like I said, this can be due to intake in foods or ingesting anything high in fructose, like I just mentioned, like red meat, soda, alcohol, beer, sugary candy, fruits, anything like that. Again, like the high purine content will lead to high uric acid, which then leads to these crystals being deposited all over the body in these joints, and they can be very painful and be inflamed and red, and be very debilitating to its patients. As far as decreased salvage of purines goes, this is going to be incorrect because if you're decreasing the salvage of purines, then you're decreasing the amount of purines in the body. If you're decreasing the amount of purines, then you're going to decrease the amount of uric acid and uric acid crystals. So that would not be the right answer. Furthermore, what could also be a right answer, though the urinary uric acid levels are high, which means that we are excreting some uric acid in the urine, decreased urinary excretion of uric acid can also be a correct answer due to the high amount that's in the urine and due to the patient's symptoms. If we're not excreting these uric acid crystals in the urine, then it's only going to build up and make the gout worse. And I do realize that the urinary uric acid numbers are high. However, if the urine was doing its job, then they would be lower, and we wouldn't have this gout. Here are just some pictures of what gout may look like. This is what it looks like in a foot. My dad has it, and he says it's very painful. Over here is just like a little picture of what the uric acid crystals can kind of look like and how it inflames the joint. The next part of the question is the patient tells us that he was told not to drink fake sugar, so he switched all those diet soda to regular soda. Now he drinks 4 to 5 liters of soda a day. And so one of the most potential impacts of this dietary modification on the presentation of gout. So to put quite simply, 4 to 5 liters of soda a day is a lot. You should honestly be drinking 2 to 3, 4 to 5 liters of water a day to be a healthy person. And like I stated, soda has a very high content of high fructose corn syrup. And remember, we talked about fructose increasing purine production, which in turn increases uric acid, which in turn increases uric acid crystal deposits, which in turn worsens gout and causes more and more gout. And like I said, this can inflict severe pain on individuals, as well as called redness, inflammation, and limit the patient's motion. Some of the foods that you can have can be, vegetables, drink water instead of soda, and ease up on the red meat and beer, because it's sometimes called the king's disease, where it's red meat and beer. So that would be a dietary modification I would suggest to this patient. All right, moving on to case number 4. This is about megaloblastic anemia. Here we go. So a 58-year-old woman presents to the emergency department. She has all these symptoms, and the workup shows megaloblastic anemia. And so the question asks, which of the following vitamin deficiencies is the probable cause of this presentation? So upon further review, deficiency in vitamin B12 is the most probable cause of this presentation. Patients that lack this intrinsic factor in the stomach are not actually able to absorb this vitamin B12, and in turn they can develop this sort of anemia. Vitamin B12 is essential in synthesizing healthy red blood cells, and when it's not in the body as much, these cells will become larger and more oval, and I'll show you a picture of that as opposed to a regular blood cell in the next slide. This can also cause hypoxemia and this patient's symptoms due to the red blood cells' inability to carry oxygen to different parts of the body. So other answers, iron is not likely, because this would lead to iron deficiency anemia, and we would see a decrease in iron in these blood tests. Iron is needed for hemoglobin and myoglobin. Hemoglobin transfers oxygen to the myoglobin in the peripheral tissues, and the cycle begins again. Deficiency in vitamin B6 is also not likely, because this causes microcytic anemia, as opposed to vitamin B12, which causes this macrocytic anemia, where these red blood cells get larger and more oval. Vitamin B6 deficiencies can also lead to dermatitis and glossitis. All right, here's a picture. These are the megaloblastic anemia cells. See how they're much bigger and more oval than the normal red blood cells. And like I said, microcytic anemia, these would be smaller and less oval. All right, so the next question, discuss how this vitamin deficiency impairs purine or pyrimidine metabolism. So a deficiency in vitamin B12 reduces the amount of pyrimidine deoxythymide triphosphate, or DTTP, and impairs purine or pyrimidine metabolism. This deficiency also affects the supply of the coenzyme needed for pyrimidine and purine metabolism, and that's called methyl tetrahydrofolate by way of dihydrofolate reductase inhibitor. Methylene tetrahydrofolate is needed for thiamidylate synthetase, which converts this DUMP to DTMP and pyrimidine metabolism, and as you can see, it leads to this DNA synthesis. So this deficiency would be right here where my mouse is on this enzyme here, and we can't create these DNA proteins, and we're not able to, and these red blood cells are going to get larger and more oval and not be able to carry so much oxygen to the body's peripheral tissues. So potential tests that we could use in assisting us. Number 1 is complete blood count. This would show hemoglobin, myoglobin, decreased white blood cell count, and decreased platelets in a patient like this. We could also use a peripheral blood smear. This would show macrocytosis, again, like the enlargement of the cells, and hyper-segmented neutrophils. We could also do a test for methylmalonic acid. This would show the actual vitamin B12 deficiency. And we could do a bone marrow exam, which is actually the most invasive, and this would definitively diagnose megaloblastic anemia. All right. And last slide, the references. Thank you. Hope you enjoyed. And that'll do.